Welcome to today's Medical Center Hour, a history of cancer care at the University of Virginia, 1901 to 2011. I'm Joan Echtenkamp-Klein. I'm the Alvin V. and Nancy Baird Curator for Historical Collections at the Claude Moore Health Sciences Library. Welcome. Cancer care has been a part of the mission of the University of Virginia since the first hospital building opened its doors in 1901. Throughout the 20th century, the momentous scientific and clinical advances that characterized biomedicine made their mark in Charlottesville as doctors, nurses, and technicians in UVA's hospital and clinics put new diagnostic and therapeutic measures to work in detecting, treating, and preventing the full spectrum of human cancers. Indeed, by century's end, UVA had become a premier cancer care center, serving the Commonwealth and the Mid-Atlantic region. The story across all those years is one of people, technologies, buildings, discoveries, hopes, and dreams, both deferred and realized. 3 years ago, a brain trust of physicians, researchers, and nurses came together to record a history of cancer care at UVA. This project, undertaken through historical collections at the Claude Moore Health Sciences Library, has culminated in the publication of A History of Cancer Care at the University of Virginia, 1901 to 2011, a book tracing the evolution of cancer care at UVA from its inception to the opening of the Emily Couric Clinical Cancer Care Center. This volume, authored by Hal Sharp, who worked in historical collections with us, and Morton C. Wilhelm, who is one of today's speakers. Its accompanying oral history DVDs and a website chronicle the dedication, skill, teamwork, and collegiality, and also the luck that were necessary for the Cancer Center to exist today. In this Medical Center Hour, just ahead of the February 26, 2011 dedication of the state-of-the-art Emily Couric Clinical Cancer Center, surgical oncologist MC Wilhelm offers fascinating looks at the UVA cancer care in earlier eras, and Cancer Center Director Michael Weber charts prospects for the future. Today's talk is a John F. Anderson Memorial Lecture, and there is information about that lecture program on your handout. Today's talk also, fittingly, is co-sponsored with the History of the Healthcare Lecture Series. There are two books listed on your handout as suggested readings: The Emperor of All Maladies, A Biography of Cancer Care, and A History of Cancer Care at the University of Virginia. We think they are complementary books. That might be a little presumptuous of us, but they do look at cancer care. Ours looks more globally, but is also firmly embedded in what was going on globally, nationally, and regionally. And the UVA bookstore has a table outside on the first floor, and the authors will be signing books after the talk. There are more complete bios of our speakers on your handout, and I encourage you to look at them. Our first speaker, Dr. Morton C. Wilhelm, MC, to my immediate right, is the Joseph Helms Farrow Professor Emeritus in Surgical Oncology at the University of Virginia School of Medicine. He has been involved with the history of cancer care at UVA for decades, playing an active role in shaping the field of surgical oncology, providing patient care, championing innovative programs like the Reach to Recovery, and educating the public. He founded the Breast Clinic and the Breast Resource Center. We are fortunate that following his retirement, he came to work with us in historical collections. The History of Cancer Project at UVA came to be, in large part, because of MC, and we thank him for his unwavering enthusiasm and leadership. Michael J. Weber, on the far end, a professor of microbiology and the Weaver Professor of Oncology, is the director of the UVA Cancer Center. He has led cancer care and research here into the 21st century. He was director of the Molecular Medicine Graduate Program and associate director of laboratory research at UVA. Speaking of nationally and globally, he is one of Thomson Reuters' top 1% most cited scientists in molecular biology and genetics, biology, and biochemistry. Thank you, and welcome to our speakers.
Thank you, Joan. Today I'm going to tell a story about the cancer care at the university over a period of about 100 years. It will be a long but rather short journey, I assure you. Now, before this, I want to thank a few people who made this possible. Very quickly, I want to thank Gretchen Arnold, who's in the audience today, who's head of the library, and gave us our support from the very beginning. Also, at Historical Collections is where all the action took place. Henry Sharp, which you met, is the co-author and co-editor. Hank, fortunately, hadn't worked in the library before, so he knew medical terms, and he was finishing up his dissertation. So he came on board and has just done a beautiful job of helping to write this entire history. Joan Klein, as you know, is the curator of the health sciences, the special collections area in the library. And she got us into a lot of this trouble, but it's been a wonderful support throughout its entirety. Victoria Myers was a real wonderful accident. Victoria was working part-time in the library getting her Ph.D. in medical history, and when we suddenly realized that Hal had a previous commitment to go to Paris, a tough commitment, and couldn't totally wrap this up, so Victoria stepped in and really polished up the whole documents in a wonderful fashion. Janet Pearson, who's sitting here, has worked at the library for some time doing a lot of their special exhibits. She picked all the pictures that you see and paid attention to a lot of details. It's been a delightful person to work with. Sonia, where's Sonia? Sonia Coleman, of course, is our creative person in the library. She designed the cover for the book, and it's helped us in a tremendous number of exhibits that go on in the library. In addition to this, we have faculty members that have been interviewed, as you were told, and this has helped to put this whole project together. Now, in the early days of the hospital, the word cancer was little spoken for two particular reasons. One, we knew nothing about it, and two, it was such a dread disease. But in the hospital, it was well known because a lot of cancer patients came in, and unfortunately, most of them died. Now, the university hospital was very fortunate that in about 1907 or 08, Dr. Stephen Watts came from Johns Hopkins as the chief of surgery. He was considered a very excellent clinical surgeon and a scholar, and he trained there under Dr. Halstead, the famous breast surgeon. Now, Dr. Watts brought to the institution expert care as far as surgical technique was concerned, and he certainly offered for the first time to patients in this area this expertise. But he realized very shortly, what was of course being now realized over the country, that we had to do something about cancer, and the first thing we had to do is to let people know it did exist. So 3 women's magazines came out all about the same time, and for the first time in this country, really used the word cancer. And as you can see, it's Collier's, Harper's, and Ladies' Home Journal. So this was a major step forward in bringing to the attention of the public cancer, and it led then to a lot of public education, and of course physician education, because physicians did not know much about cancer at that particular time. Now, a good thing happened in Germany about this time. William Röntgen discovered X-rays. At first it was just to take a picture. Then he realized that it could do more than that, and you could actually treat with X-rays, at that time, superficial cancers. The Curie Institute about the same time also discovered radium. Radium was a powerful tool to treat, there again, superficial cancers, but we knew relatively little about it, about its dangers or what it could really be used for. Now, World War I came along, and the university sent a hospital called Base Hospital 1 over to Europe, with the chief of surgery being William Goodwin, one of our surgeons, and the head of nurses, Margaret Cowley. Now, one advantage to this was that while they were in Paris and in France, they got a chance to visit the Curie Institute. So they had the opportunity to learn a great deal more about radium than had been really published, of course, in this country at that time. So when they returned, Dr. Goodwin taught Dr. Watson to buy radium, which he did incidentally with his own money, so that we could have the first radium treatment in this particular area. Now, in 1929, a major event was taking place at the university. The new medical school building was going to be dedicated in the fall of '29. This was a great occasion because for the first time we could have the faculty and the students and the nurses and everybody together to teach medicine and to actually help in patient care. The last day of the big weekend conference dedicating the building, the 1929 crash occurred. This, of course, was a major event, and not much happened as far as cancer research or anything else for a number of years. But very fortunately in Charlottesville, there was a man named Mr. Paul Goodloe McIntire. If you live here, you see the name all around town on many of the buildings. Well, Mr. McIntire decided that he wanted to give the medical school $100,000 to start a cancer center, and this was in honor of his wife. Now that was a tremendous amount of money in 1933. Well, the university was sort of appalled, it was overwhelmed. They didn't really know what a cancer center was. So they sent Dr. Vincent Archer, who was our first radiologist, and Dr. Goodwin up to Memorial Hospital, which was the only real cancer hospital in this country, to learn, one, sort of what a cancer hospital or program was, and how did they run it. So they went up, and we also sent up Dr. Parker from the Department of Surgery to sort of learn how to use a radio. What were the risks and how could you really use it safely? Well, the group came back and made a recommendation to the dean and the faculty that we actually set up a separate cancer facility, either a separate building or a separate center within the building. Well, this didn't go over real well because chairman of departments don't really like to have centers because they're afraid that they're going to lose the autonomy of their personnel and also lose money. So as has happened a few times over the last 100 years, we didn't really get a cancer center, but we did get a McIntire Tumor Clinic. And that clinic was actually one of the first in this region, modeled after Memorial. All the various disciplines treating cancer came together and saw the cancer patients and planned their care. And this was really a first of what we now call our tumor boards. The rest of the McIntire funds probably went to take care actually of cancer patients. Now, the government as a whole, realizing the seriousness of the cancer problem, established in 1937 the National Cancer Act, a National Cancer Institute. Now this was supposed to be sort of a umbrella advisory type of institute at that particular time. But interestingly, in Charlottesville, in 1944, Dr. George Cooper, who was one of our radiation therapists, had for the first time 5 years of data from the McIntire Tumor Clinic. And we could now look at how was cancer doing. Well, it was doing terribly. 25% survival rate for cancer at that time. Well, this was pretty much of a shock. It was a sort of a shock locally. And a group of individuals, strange group, got together and decided they were going to form a clinic. It was called the Bessie Dunn Miller Clinic, and its purpose was to offer free screening. Individuals could come into this clinic without paying a cent and get a physical examination and learn something. We hope was that we could detect cancers earlier. People would come in, and this was really one of the first early detection clinics. Now, when World War II came along, the military was fooling around with mustard gas, and a propitious accident happened on a ship. Some sailors were exposed to mustard gas, and suddenly they found their blood counts were dropping out the bottom and their lymph glands disappeared. Well, some smart clinicians said, oh, that might be good, because in leukemia, your blood counts goes off the roof and your lymph nodes get big. So this started the whole era of cancer chemotherapy. So now we have, joining surgery and radiation, we have chemotherapy to treat the cancer patients. Now, the administration did recognize that this was probably pretty important, and so they hired Dr. Vincent Hollander to come onto the faculty as the director of the cancer program. He was a national scholar in cancer research and clinician, and really did a great deal to get the program going. After a pretty good number of years, I think he decided that the future for a center was not the real bright, so he left. But in 1950, the state health department did a major thing. They formed a division of cancer control and began a cancer registry. Now, cancer was not a reportable disease up until that time. So we really didn't know how many cancers we had in the state of Virginia. We didn't know what kind of cancers we had, and we didn't really know what our survival rate was. So the cancer registry was really a major step to give us a handle on the cancer program. Now, the NCI started up actually a whole separate center for chemotherapy because this was exploding. Now, Dr. Wagner decided that, gee, we really, excuse me, my slide didn't flip. There we go, okay, excuse me. At the same time at the university, at least the administration didn't realize the importance of the cancer center. A lot of the faculty did. So the various major departments actually set up for the first time divisions of oncology. Dr. Muller set up a division of surgical oncology, medical oncology set up, combined the two divisions of hem-onc and oncology to call it hem-onc, and radiation therapy actually set up a whole division of radiation therapy. And this was a major step forward, particularly in radiation therapy because Dr. Keats had come on board after Dr. Archer stepped down, and everything was really in sort of bad shape. We hadn't had the money to buy any new radiation therapy equipment, and so Dr. Keats stepped in and really got things going, and Dr. Constable was a world authority actually in radiation therapy, and so they now set up their own division of radiation therapy. Now, the government and the president of the country at the time, I think it was Nixon, decided they were going to have a war on cancer. So they changed the whole focus of the National Cancer Institute. It was no longer supposed to be just sort of an umbrella organization. It was actually supposed to set up major cancer centers within this country, funded by the NCI, to really do research and teaching and do direct cancer care in this entire country. Now, the team at the university, or the clinicians involved with cancer, of course, got very excited about this, and they said, oh, we ought to be one of these centers. So they really got together and started mobilizing everything. They brought in consultants, and they thought they had an absolutely superb program of good basic science and good clinician work. Unfortunately, they didn't realize there was a little turf battle going on behind, and they found out as they were approaching the site visit that some of the administration and some of the chairmen of the departments didn't really want the center. So we were not funded. And that was, of course, a major blow. Some people left, and everything was sort of in disarray as far as the cancer center was concerned. But they did appoint Dr. Robert Wagner, who was head of microbiology, as the head of our cancer program. They wouldn't call it, of course, a cancer center. Now, an interesting thing happened about this time, and we really have never been able to find out how. But in view of the fact that the administration didn't really want a cancer center, something funny in Richmond came about. In 1978, the Virginia General Assembly mandated that the University of Virginia would have a cancer center. And as I say, we still don't know exactly how this happened, but to say the least, the administration was caught a little bit off guard. So they said, okay, we will let Dr. Wagner at least have an office. So we had a small office up on the fourth floor, had a secretary who happened to be my daughter at the time, and he hired Tom O'Leary, who was to head research administration and director of programs. Dr. O'Leary remained with the program up until last year, all these many years. Now, Dr. Wagner also set up a small clinical cancer committee. We met every month down in his little small office and trying to plot how we were going to get a real clinical cancer center. He was working hard as far as the basic sciences were concerned, but it was the clinical that he really needed a lot of support. He did, however, apply for a very basic cancer grant. He got a small grant shortly thereafter. Now, another thing happened which was really a major move in this institution. Dr. William Thurman came on to replace or follow Dr. Birdsong, who had been chairman of pediatrics for years. Dr. Thurman was a pediatric oncologist. There weren't very many in the country, and he was an outstanding figure. And just by chance, there happened to be on his residency staff a gal named Sharon Hostler. And so he and Sharon Hostler worked closely with Dr. Thurman in certainly the early treatment of children with cancer, particularly leukemias. And as Dr. Hostler said, when she first started with looking at children with leukemia, the mortality was 100%. Within a relatively few years, the mortality was 10%. But one of the things that Dr. Hostler did, which was unique and a real model for this country, She was given a lot of different jobs by Dr. Thurman, and one of them was to go over and act as a temporary head of the Children's Rehabilitation Center because the director left. It didn't take her long getting over into the rehab center to realize that children with cancer needed as much rehabilitation as all these other children which were over there. So she really moved children with cancer over to the rehab center so they could get the benefit of the education and the other rehabilitations. And this was a real first in the country and a model certainly. Now, we had to start thinking a little differently about cancer because we now had all these three modalities. We had surgery and radiation and we had chemotherapy, and people were actually living. So we have to look at cancer as not just an acute disease, but as more of a chronic disease. And this then made us have to think about the whole patient. You're going to have them carry them through their whole treatment and their living with cancer. And Dr. Karen, who was in anesthesiology, set up the first pain clinic. And he very quickly found out that most of the patients he was seeing with bad pain were cancer patients. And he realized that they needed a little more than just to treat their pain. Now, he talked Dr. Gerald Goldstein, who was one of our medical oncologists, into going to Italy and spend about 6 months looking at a palliative care program in Italy. They had been sort of the leaders in the world, really, in this type of care. Dr. Goldstein came back, and by that time, the university had taken over the old Blue Ridge Hospital. So Dr. Goldstein set up not only an oncology clinic, but a palliative care clinic and center. And this was really a major success and a major advance in taking care of the whole cancer patient. Now, when Dr. Goldstein retired, at the time that the university decided they were to close down Blue Ridge. So our program was sort of fallow for a year or two, but the Hospice of the Piedmont came on board into this area. And they sent one of their nurses to the university on a sort of a permanent basis. Then one of the residents in medicine, Dr. Carlos Gomez, decided that this was going to be his mission in life, was palliative care. And he joined the faculty after his residency. He got a Robert Wood Johnson grant, which was a major grant, and set up really a superb, complete palliative care center here, and it's continued to be that way. Dr. Leslie Blackhall came from Memorial Sloan Kettering, which there again had one of the first in this country, and she continues to direct this very excellent program. Now, Wagner still had in the back of his mind that we really ought to be a clinical, we ought to be a designated cancer center. So he and Tom O'Leary got in the car and drove up to Washington one day to talk to the people. And this was an interesting conversation, as if you read this. It was a rather short meeting, to say the least. So driving back home, O'Leary was sort of quiet, a little bit down. He looked over at Wagner, and Wagner was smiling as happy as he could be. This was the challenge he needed. He said, well, this really, if you knew Bob Wagner, this boy has stimulated him. And so he came back, and he realized, though, we still had a little bit of a problem clinically in the medical center. The question was integration or collaboration. The same old turf battle. All the cancer people wanted integration. They wanted to get together. Let's have multidisciplinary care in treating the cancer patient. Some of the department heads and some of the administration, well, why don't we collaborate instead of integrate? And this sort of was an overriding tone. Well, Wagner realized all of this, but he kept on. He was not a man to put out easily. And so he set up what he calls the structure of a cancer center. And you can read this. It included basic science, research, and education, and patient care. Now, in 1987, Dr. Wagner had sort of given up at the moment being a clinical cancer center, and he submitted a major grant to be a basic science cancer center and was awarded one. He had a superb team of experts, but 3 years later, the NCI decided that they were no longer going to have basic science cancer centers, but they were all going to be clinical centers. But Dr. Wagner, during all this time with his small committee, which met every month down in his little crowded office, had been plotting for this. So when the time came, he was ready, and we did get designated as a NCI designated cancer center, and we've continued to be so since that time. Now, along about the same time, some major changes were taking place in breast cancer. mammography had come on board. For the first time, we could take an X-ray picture of the breast. Now, we didn't know what that meant at first, but fortunately, we had a radiologist named Ellen Paredes on board. She devoted her entire time to mammography, and we began to learn what was sort of normal and abnormal. It was a great learning curve, not only for her, but certainly for me as a surgeon. But it set up a major program. Now, but it created a dilemma as far as breast cancer patients were concerned, because suddenly they had options. Before, it was, do you have a mastectomy or don't you? You know, that's all there was. But now, you had multiple choices of therapy, but you also had a lot of other things, other questions. So, I happen to be on the board of the State Cancer Society and the National Cancer Society with Audrey Mars, who was head of the Mars Cancer Company. So I talked Audrey to giving us a rather major grant to be used, and I decided to use it to set up a breast resource center, mainly because we thought women needed a place where they could come and they could get the answers they needed. Of course, since then, this has expanded greatly. We hired Diane Cole to be our educator, and she's continued to work wonderfully in this patient support field. We now support everybody. And then another interesting thing happened. A friend of mine who happens to be in the audience called me one night. She said, you know, the Charlottesville Track Club decided they want to have a race for breast cancer. And do you have any idea what we might do with the money? I said, oh boy. Fortunately, we had already set up the resource center, so we were ready. So a partnership was formed with Diane working closely with the board of the track club, and that has continued now for some 20 years. The first year we got $700 and we were thrilled. This past week, as you may have all noticed, we got $350,000 from this is the largest women's race in the country apparently. And that's been a major help because all the programs that we give are free. So this means that we can support women with all of the many efforts by this track club money, a major thing. Now, I'm going to quickly go through the technological advances that happened mainly in the last 20 years. It's really sort of phenomenal to have this happen. Radiology has been phenomenal in what's happened. Imaging has just taken off. But of course, all of these things make a big difference to the cancer patient because we can find cancers at an earlier time, but we also can delineate the cancers so they can be treated. For instance, the CT scan, for the first time, you can get a cross-section of the body, and not just a plain picture. Then MRI came on board, and we could not only see things, but we could see nerves and blood vessels. Huge difference when you're planning a big major operation or radiation therapy. Now, Dr. John Jane happened to hear about what's called the gamma knife. Well, it's not a knife at all, but over in Sweden, Dr. Steiner and his group had come up with the idea that gamma rays, by fixing a special machine that fitted over the head, could be focused into a very small spot of the brain, maybe 2 or 3 millimeters, and they could put tremendous amount of rays into this one spot without damaging the intervening tissues. And it would only take one zap. Now, I first started out to treat vascular abnormalities in women, you know, these AV aneurysms, and they would come in here from all over the world. We had to have, Dr. Jane had to set up a group of interpreters because somebody spoke a different language next day. But anyhow, he was able to get Dr. Steiner to come here and set up one of the first gamma knife units in the country. They now are working to see whether this whole technique, which has evolved to treat metastatic brain cancers, can be used to treat maybe cancers of the head and neck region. And that's really a very exciting research project. Now, Dr. Peyton Weary, who as you all know is head of dermatology, found that with the advent of all of us changing the clothing we were wearing, he was seeing skin cancers. First he only saw them with workers, you know, on their hands or their face, but now he was seeing them all over the body because everybody was being exposed to all these rays of sun, which we call skin cancer. He set up the first skin cancer screening clinic in Louisa, Virginia in the country. And he found out, though, they were seeing also a lot of skin cancers on the face. So he brought in Dr. Parlett to set up a Mohs surgery unit here. This is a technique which allows you to take less amounts of tissue and still get margins, and has been a real first in this department. Now, at the same time, of course, the dermatologist realizing the incidence of melanoma was truly exploding. We had learned by now that molds which had been exposed to the sun over time, or maybe a bad burn 15 years before, could turn into melanoma, which is a rather devastating disease. Now again, we were very fortunate. Dr. Craig Slingeloff, who went here to college and medical school, had taken his surgical training at Duke, where they had a major melanoma center. Dr. Slingeloff came on board, and as you all probably know, is now one of the leading authorities almost in the world in the development of vaccines for melanoma. So that is certainly a major effort for melanoma patients in this area. Now, the big thing is scopes. Now scopes, you know, Dr. Fletcher Woodward in 1930 bought in his own money the first, that's always been a little problem, money around here, bought the first bronchoscope. This is a rigid tube that you could actually look down the throat and see things. Well, this was, of course, a tremendous early advance. As we all know, scopes have gone, the urologists have used them, the gynecologists have used them. Everybody's used scopes. But the major thing that happened is when you developed optics, you could then have a flexible scope. A rigid scope was, of course, very limited. You could only look up a certain distance because it wouldn't move around all these curves. A flexible scope suddenly means that you could look almost everywhere in the whole body. And you could then do biopsies. Well, they said, you know, maybe we could do a little more than biopsies. So the instrumentation, these beautiful little fine forceps and everything that you could do through long instruments and a scope as big as your finger, you could see like you're looking in the whole belly. Now this was a major step forward, and then the next logical question came is, could you treat cancers with scopes? It would be less invasive, and indeed it has now been determined that certain abdominal cancers can be treated with a scope. Everybody was worried, are you going to spread the cancer, or you're not going to do as good enough an operation? That is now, under people who know how to do it, is found to be possible. See, the major advances as far as taking care of the cancer patient. Now, there's one thing further, of course. The industry was using robots. Everybody sort of talked to robots. Well, Dr. Gillenwater heard about this machine developed in Europe called the Da Vinci machine. And lo and behold, this is a machine that does the operation. The surgeon sits over in the corner of the operating room in front of a computer. The arms of the robot are made through little, put into the belly through little small incisions, and the surgeon does the operation. He guides the hands of the robot from his computer. But this has been amazing. Dr. Sears, who succeeded Dr. J. Gillenwater, said, you know, now all of our prostate operations practically are done this way. He said, I used to lose a couple pints of blood. Now we may use 100 cc's. The patients used to go home in a day or two. Major, major advances, and this robot is now being used in other abdominal surgery. Now, there is a problem with all of this technology: money and experience. These are highly technical procedures. Now, Dr. Bruce Shermer actually set up a training course for general surgeons, learn how to do gallbladders this way, because they hadn't been trained this way, and they really didn't know how. So we've had to have training programs. The problem with the Da Vinci machine is that it takes a long time. Dr. Sears estimates it takes 100 cases under close supervision or with a mannequin before he thinks a surgeon should do one of these procedures. So the problem is money. They're all expensive. All technology is very expensive. It's changing all the time. So I don't think these problems are going to go away. You have to have someone with experience using the technology, and you have to have money to get the new equipment. Now, here we are some 80 years after McIntire gave us 100 grand, and we're actually going to get a cancer center, amazingly enough, a real physical cancer center. But you have to have what we call a tapestry of care for the cancer patient. We have to be able to take the patient through diagnosis, through screening, through treatment, and then how to live with the fact that they've had cancer. This is how our palliative program comes into being. So we consider that what we do have for our cancer patients is a real tapestry of care. Now, Dr. Myers succeeded Dr. Wagner when he stepped down. He came from the NCI and was here about 6 years, and his major area of interest was in prostate cancer. And Dr. Michael Weber then succeeded Dr. Myers. Dr. Weber was, as you found out, a very well-known scientist, and he came on board as head of the cancer center. Now this was a little bit of shock at first because he was a scientist. He was not a clinician. He hadn't had to deal with all the doctors and surgeons and their attitudes and changes and all that sort of business. And he also hadn't had to deal with patients. But he very quickly adapted, and he has led us over 10 years now through recurrent grants of our center and made it really one of the leading centers, particularly in this region. Now, Dr. Peyton Taylor is GYN oncologist. I'm sorry he couldn't be here today. He started back on the little old committee that we used to sit in Wagner's office. And during all this time, he's never lost the goal of us having a true cancer center. He's been the medical director of the center. He has also kept the faculty pulled together to be a true integrated cancer center. And then an unlikely person appears on the screen, and that's Dr. George Beller. Dr. Beller, as you all know, is head of cardiology and a very internationally known cardiologist. Well, what's he doing with the cancer center? Well, he happened to marry Emily Couric. Emily Couric was a state senator and destined to probably be the first woman governor of the state of Virginia. Unfortunately, Emily developed pancreatic cancer and was unable to carry out some of her dreams. But George decided that he was going to see that we had a cancer center named after Emily Couric. Now, how he accomplished this politically is sort of remarkable, but he did. And he went behind the scenes, and pretty soon the state legislature did say, you can have an Emily Couric Cancer Center. And this is sort of where we are today. Now, Dr. Tom Parsons, in his interview, I have this quote, and only the last sentence will I read, and it says, "We forget why we're at the University of Virginia and why we're actually doing this, which is to make sure that the next generation lives better than we do." Thank you very much. Going to tell us what a cancer center really is.
Well, thank you, MC. That was a wonderful run-up to where we are. I'm going to need to have that thing, otherwise we'll be looking at this thing for the next 15 minutes. There we go. This was actually your last slide. And where do I point this? Anywhere. There we go. So I want to start with the question of why we need a cancer center. And it really starts with the disease. Everything that we do is driven by the nature of the disease. And that is, it's a disease that's incredibly complicated. I don't need to enumerate all of the different things that are here. But you can't deal with this disease with a single clinical specialty, and you can't understand it with a single scientific specialty. We need multidisciplinary approaches to care. And this is an example. This is actually a 2-year-old picture of the breast team at the tumor board. And those of you who are in the area know that you can pick out the nurses and the social workers, the nutritionists, the chaplain, the surgeons, the radiation therapists, the radiologists, and the medical oncologist, all who are working together in a group looking at every single case and bringing together an integrated view of how each patient is going to be best treated. We have several of these multidisciplinary care teams that work together, and all of these teams are supported by the Cancer Center, and most of those are hosted by the Cancer Center in our conference room. We also need to have a multidisciplinary approach to research. Cancer is a genetic disease, so we need to understand the genetics of the disease. The genetics changes the structure of proteins that act inside the cell, so we need to understand structural biology. That affects the biochemistry of those proteins, which play out in terms of what the function of the cells are that those proteins are expressed in. That affects the developmental biology of those cells, how they differentiate, and the physiology, how those cells interact with the organism as a whole. It also affects the susceptibility to disease, epidemiology. The psychology of the disease is unique. It affects the way that we are going to screen and certainly the way that we want to prevent. So what the Cancer Center does is we are the mortar that holds the departmental building blocks together. And we try and put it into a shape that serves the needs of patients. And I think the disagreements that MC referred to between departments and centers really has to do with who's the architect, not who has the blocks and who has the mortar. So I'm often asked, you're a scientist. Is your cancer center about research or is it about patient care? And I say it is 100% about patient care. And I say that not just because I'm being defensive, but because I really believe it. I come from a cancer family. I passionately find unacceptable the idea that a third of the people with cancer are going to die. 1970, when the National Cancer Act was passed, half the people with cancer died. Now, after 40 years, we're down to only a third of them die. So we need to bring the best care to help the patients of today. So that's patient-centered, evidence-based, compassionate. And we also help the patients of tomorrow. And those patients we help with research and education. And we need to be as, feel the same urgency with respect to the patients of tomorrow as we do for the ones who show up in clinic today. There are many more of them, actually, even though they're not sitting in front of us. And trying to strike that balance of dealing with who's here today, knowing that the therapies that we deliver are inadequate, while at the same time trying to invest in helping the patients who are going to be here in the future. That, I think, is one of the major strategic challenges that any cancer center director and actually administrators at NCI and so on have to face. The overall function of the Cancer Center goes from basic research, which we try to feed into clinical research.
You don't want to use the basic pen.
Oh, that's right. Clinical research, patient care, and community outreach. And I'm going to start with the community outreach part and show you where we are in the Commonwealth of Virginia. The University of Virginia Cancer Center is among the most rural of all of the NCI-designated cancer centers. I think everybody knows what our geography is. This is Route 64. It's the only freeway, interstate highway that comes through here. More than half of our patients have to drive over the mountains in order to get here. Average commute is about 2 hours. Many of our patients come from Southwest Virginia. There are counties out here where between 25 and 50% of the people with cancer actually drive 5 hours to come to UVA. These people are also our patients. This is actually the medical center. This is a picture of the medical center primary and secondary catchment areas, service areas. How do we reach those people? Well, one of the ways that we believe they can be reached is by telemedicine and trying to bring the fruits of the things that are happening or going to be happening in the Couric Center out into the community so that people don't actually have to come here. And that initiative is led by Karen Ruban and David Cattell-Gordon, and we have some funding from the Tobacco Commission to help the cancer part of that occur. We've been very active in the community in terms of outreach with the Cancer Action Plan Committee. And the way that we proceed is by trying to get the best people, putting them together in collaborative groups, and getting all of the collaborative groups to collaborate with each other. Here are the people who are doing it: Paula Fracassos, Sally Parsons, Jeff Weiss, Peyton Taylor, Dee Eady, Dina Halme, Jay Fox, Chris Moskalik, Jim Warner, and Craig Slingloff represent the senior leadership group. And the research part of the Cancer Center is organized in 5 programs that reflect the genetics, the protein chemistry, the cell biology, and some of the systems that are associated with cancer. And each of those programs has program leaders: Tom Parsons and David Brodigan, Craig Slingloff and Vic Engelhard, Kevin Lynch and John Bushweller, Paul Fracasso and Peggy Shupnick, with a lot of input from Sally Parsons. And in the genetics, it's Joyce Hamlin and Aninja Dutta, and as Joyce steps down, Jim Larner is going to step up as a co-leader of that program. We're very fortunate for the first time to have not only a new clinical building, but have dedicated space for research. And that's the Carter Harrison building, where two of the programs are going to have their, or do have their hubs. One is immunology, immunotherapy, and the other is women's oncology. And the basic idea, MC referred to the tapestry. I'm not a good enough PowerPoint person to actually make a tapestry. But you get the idea, which is to weave a tapestry of scientific themes with the warp of scientific themes and the weft of the clinical care groups. And how do we do that? Well, first of all, it's people. So recruiting and retaining the best people. Over the last 5 years, this is all now from our NCI Cancer Center renewal, we've helped to recruit 26 new people to the university. 13 of them are physicians or physician scientists. Many of them are oriented towards clinical trials, which is an area that we have historically needed to develop, as MC has indicated. Of the remaining 13, 8 of them are part of the omics world, either systems biologists, bioengineers, computational biologists, or involved in genomics, which is, I think, an important part of the future of research. These are some of the ongoing recruitments. We're trying to recruit into immunotherapy and women's oncology. We have a team-based recruitment strategy for getting additional medical oncologists and translational lab investigators, where the idea is to grow some of these organ site-specific teams, and a high priority is to recruit a phase 1 developer. We're partnering with departments to recruit into neuro-oncology, and we've, as many of you know, helped to recruit Mary Laughlin, who is a stem cell transplanter. At yesterday's STEM medical school, Steve mentioned that the chair of public health sciences has resources to help us recruit into the area of molecular epidemiology and biostatistics in growth towards a comprehensive cancer center. And we believe that there still is room for growth in the basic science departments for people who have a cancer orientation in systems biology, signaling, tumor biology, and the microenvironment. Resources and incentives. I'm not going to talk about the communication part of it because we don't have a lot of time, but we do spend a lot of time helping people communicate. Pilot project funding is another thing that the Cancer Center does. We issue RFAs. We have a competitive process to award money. Over the past 5 years, we've spent $4 million in pilot projects. If you look at the projects that were funded between 2006 and 2009, where now you can look at some of the output, the information gained with those projects has yielded 34 grants, 21 were from the NCI, 4 were from the ACS, 3 from the Department of Defense, 1 from Susan Komen. And the entire funding yield is $39 million. So an investment of $4 million has yielded $39 million in new external funding with a 14-to-1 return on investment, which is a remarkable achievement. And then there's infrastructure, which is to help people actually do their work. And there are a number of core facilities that the Cancer Center has historically helped to support financially. We put about a little over $500,000 a year into those facilities, mostly from the CCSG. And here's where some of our money has been spent. The Office for Clinical Research, over the last 5 years, $2.5 million. Biomedical Informatics is Jim Harrison's shop, $900,000. Biorepository, that's Christmas Felix operation, $600,000. Biostatistics, $600,000. Equipment for the other cores, we just contributed $75,000 to get a new confocal microscope, and then $2 million into the laboratory cores. So this is how we try and keep the machinery of research and patient care integrated and functioning smoothly. And so the question always comes up, well, where's all this money coming from? And I've shown this slide every time I've given a State of the Cancer Center talk. I think the first one was 8 years ago. And I always had Commonwealth of Virginia on this list. And after each time, there have always been people who sort of say, you know, you're just, you know, what are you smoking? This is not going to happen. The state of Virginia is cutting things all the time, reducing its support for universities. But I've always felt that in the area of healthcare, that they would like to provide more support if we would let them. And I think that it's a new era. I'm not sure exactly all of the things that have changed. We have a new president, we have a new dean. But in any event, we are now in an environment where it's much more likely that we are going to be seeing the kind of support that we've always expected. Here's what we have been getting: $1 million from tobacco settlement funds, a checkoff on the state tax return, $1 million per year in the state budget with the Massey Cancer Center at BCU. These are all initiatives that were started by the Massey Cancer Center, and I worked very hard to establish a relationship of trust with their director. And when he's asked for help from the legislature, he's always asked for help for the 2 NCI-designated cancer centers. MC indicated that there was an uphill battle to get state funding for the Couric building. I think that represents a real milestone in state support. And now we have in the current proposed legislative budget a request for $5 million per year for the Cancer Center. And the Joint Commission on Healthcare has suggested that this go up by $1 million a year to $10 million a year for each of the 2 NCI designated cancer centers. I'm very hopeful that this will actually come about and will represent a stable funding source, that the kinds of things that MC has talked about and that we're projecting will actually be occurring. So by using these funds to serve the citizens of Virginia, we increase the likelihood of additional state support. There's a virtuous cycle of supporting the people and getting the support from the people. So the 4 Ds of translational research are discovery, development of those discoveries into practical use, delivering them to the clinic, and distributing their benefits to the community, the Commonwealth, and the nation. And that's how hope is generated for changing the odds on cancer from 30% survival, 60% survival to 100% survival. So thank you all very much.
I'd like to thank both MC and Mike for wonderful presentations. Before we go to questions, and we have a few minutes for questions and comments, I'd just like to say that this Medical Center Hour is part 1 of a 2-part presentation. Next week's program, the 9th of February, is called Healing by Design, the Emily Couric Clinical Cancer Center. And we feature the chief architect of the building and the chief landscape architect of the building, along with Peyton Taylor, the medical director. They will be talking to us about the way the building was designed for healing. And as Mike Weber was telling me earlier today, and Steve Dukoski mentioned yesterday, it is a truly astonishing building, one of the most impressive clinical facilities ever. And I think with the architects here in a program co-sponsored with the School of Architecture's Center for Design and Health, we'll be looking at some of the ways that in addition to basic science and good clinical care, good design makes for good health and good healing. So I invite you to come back next week for part 2. Now for questions and comments about part 1, this wonderful look at the last century and sort of where we are now, poised to dedicate a new building and move on. Any questions and comments? Okay, let me get this mic over to you.
Where you can shout.
No, it won't go on the tape. Just shout.
One more you're going to be getting your exercise. But maybe next time we'll have the microphones on.
John Owen, retired professor in internal medicine. I want to compliment the authors on an excellent review of history, and we always talk about the lessons of history. And I would like to ask the MC, off the top of your head, as you look at the history that you've studied so carefully, what are the strengths and what are the weaknesses of the University of Virginia in trying to attack this problem?
I think certainly, there's one weakness that I think is going to be a continued weakness, and I think this is probably true all over the country, is money. All of these things that cost a tremendous amount of money, as we talked about the technology, and I think that's an ever-growing problem, but I just think we just have to live with that. The other is leadership, and I think there again we've had individuals who've had a passion to see that this happen, and I think that's what it takes. Bob Wagner was just an amazing individual. If all of you knew him, he was a very quiet sort of a person in some ways. Boy, he was like a bull. And when he took hold of this project, he just very carefully crafted how he can go about doing it, and he did it. And I think, to me, leadership is one of the major things that you see through all of this. I think what Sharon did, the vision for her to see that, it's pretty obvious. You know, these kids got cancer, and they're here in the hospital, and they need education, they need support, and here you've got a whole center over here doing that. So she put it all together. So you need vision and leadership, is I think what you really need, John.
I'm Dan Moeller, a retired professor in hematology oncology. And this is mainly just a comment on the tremendous amount of work that MC Wilhelm did in pulling all these people together, putting this big project together. He worked endless hours and has done an absolutely superb job and should be congratulated by everybody.
And I can add that, you know, having been here, you know, for 27 years, that it's not just the history project that MC has been a leader in pulling together, but actually the Cancer Center itself, and the vision of multidisciplinary teams, and trying to get somewhere beyond volunteerism in terms of putting together the interdisciplinary care that's essential for patient-centered operation.
Thank you. I want to say that this has really been a group process. And at the end of this several years, we all still like each other. And we speak to each other, and we have had a good time together, even though it's been tough at times.
Well, it's bonded you all, I think. I'd also like to say, just before we end, that, again, the books are available out the upper door, and both MC and Mike will be there to also take your other questions. I think at this moment, too, the book is a signal accomplishment, because it really does consolidate where we've been for the last 100 years. And as we take this new step into a new century and into a new building, I think we have a good idea about where we've all come from, where some of the energy is, where some of the challenges still are. And this is one of the excellent uses of history as a guide into the future. So thank you all, and thanks to the library for sponsoring this project, and we hope we'll see you next week for part 2.